Good afternoon, ladies and gentlemen. I have been given the most difficult work to do, but do I have anything in there? That question mark. Is there anything that I kept from all these people who have talked? Perhaps nothing, but at least the question mark. I would like first to thank everyone who has come for this grand round. The room is quite full. I am not so sure whether because there was an older than 60-year-old in the house. So, Professor Mayanja, I think we shall always keep putting your name on the posters so that we can have the house full. Number two, I am not going to repeat and dilute all that have been said. The best thing to do always is to get involved in the politics of dilution. Make everything else look ordinary and nothing. But when we get there, what do we benefit from? So we had the patient being presented to us, 27-year-old. Was this a patient with sickle cell disease or was he a sickler? Is he a patient who has sickle cell disease or is he a sickler? He has a girlfriend, but he does not have a child. The question that Professor Mayanja put at some point is, when we have a patient with sickle cell disease, who should they marry and how do they get to know who to marry and who not to marry? Do we, by the way, decide to have children, and how often do we decide when to have the children? Did this patient, 27-year-old, have addiction or did he not have addiction? Did this patient have priapism? I think the answer was yes. And priapism were about, Professor Mayanja, what did you teach me? There were 5 P's. Persistent, painful, purposeless penile erection. I don't know whether those are 5 P's. Is it quite easy to fake it? Have an erection for as long as more than 10 minutes without a purpose? So that is the patient. Happy, I hope you are happy with the summary. We do know that the third agenda for the 21st century, we all need to be happy. We need to grow older than Professor Mayanja. We need to become immortal, and we need to become more God-like. Unfortunately, not in our behavior, but in our minds. So, the second presentation was by the professor. She talked about all those that you have had. I'm going to emphasize only one thing, which she has said. For every patient that you have before you, in order that you may be able to manage that patient well enough, you have got to understand the pathophysiology of what is going on in that particular patient. And therefore, I wrapped what she said about that as do an appropriate clinical pathophysiopharmacologic matching. What do you have in the clinical history and in the findings? Can you use that to explain what could have gone wrong and what is going wrong in the patient? And when you have that pathophysiology clear in your head, can you match it with the medication that you have? Can you use a medicine that can reverse the pathophysiologic process? Can you go forward and stop the progression of that pathophysiologic process? If there is anything else you want to remember, remember it was her birthday today. So the third presenter, Dr. Peace, she talked about complex pain. And I think the main thing that we want not to forget is not the complexity in what she talked, and it's not the complexity of pain. It's perhaps how we should approach a patient who has got persistent and pain. Persistent symptoms, pain being one of such. She concluded by talking about the biopsychosocial model. And I would like to add to that model, which has been tested in many places and found valid, but perhaps in some parts of the world, we might want to add the spiritual aspect to that, so that we might say peace, biopsychosocial spiritual model. If that makes you happy and that makes you manage your patient better, deal with the spiritual aspect as well. On one of the slides of peace, there was an element of neuroplasticity. And I would like to say, to that effect, stimulate your brain, stimulate your brain, and stimulate your psyche. The more you keep on stimulating, putting a particular stimulus to the nervous system, the more you are going to have some expansion, perhaps not only to the central nervous system, but even to the peripheral nervous system. And if we have got a well-adapted individual in its or her or his environment, then I think we can always choose the appropriate stimuli to make us be able to expand our capabilities and opportunities. It is only when we have done that that we can perhaps enjoy one of the agenda of the 21st century, that is being genuinely happy. We progressed from there to the psychiatrist. You are still left this question. Wonder whether it is to meet the three. 1, 2, 3. One is inside the brain. Well, if there is a brain there. Raymond answered to us the question of how these medicines work, the medicines that we are concerned with, that is the opiates that could probably cause addiction, that could probably cause dependence. But Raymond told us that while it is good to tolerate, I almost asked you to stand a little bit and stretch your legs so that you do not develop DVT. But I thought you perhaps would not tolerate that, given the fact that you are so many. So I failed to ask you, would you have wanted to stand a bit? I see people shaking their head in the horizontal plane. Well, if you can tolerate a clot in your calf, it's quite okay. But the moment the patient develops tolerance, Raymond told us, and they develop withdrawal symptoms, then we need to know that we have started a journey down the path to dependence, addiction, and unnecessary use of a medication. But he emphasized that we should not look at an event, we should look at a pattern. The pattern which is expressed in the conduct of the patient, in the behavior of the patient as regards their symptoms and their craving for the medication or their use of the medication, as well as the way they talk about their prescriptions to themselves, but also to others. We were told by Happy that the patient on the ward would inject himself, but inject others as well. And so we ask ourselves, while we are concerned about tolerance, we are concerned about eventually getting dependent on a substance, are there some other benefits outside what your medication or whatever your intended purpose was that this patient or this person is deriving? If the patient is continuously using that medication because they would like to derive some other benefit different from the primary effect of that medication, perhaps that pattern needs to be recognized. and treated separately. Do we need, Raymond seemed to have asked, to ask patients about how they feel, about what they feel, about the medication that they are taking? He concluded by saying that I am going to be predictable. But he concluded by saying these patients who are on their road or have developed dependence can be very unpredictable. For those of you who have known religion for a long time, unpredictability forms the basis for a better life and a happier life. Moses has opened for us the door to using a substance that sometimes causes people to hallucinate. But perhaps if you want them, now them here ask the doctors to use, I heard Professor Maya say don't tell them. I think the them now is us. We should not tell ourselves that when we give ketamine, the patients hallucinate. But it was quite very clear about the dose that we need to give, and it was quite very clear about when we should decide that use of a non-pain medication, use of a non-conventional pain medication can be brought into the management at a particular point in time. And so it is not going to become a guideline that we are going to be having all our sick class on ketamine. I do remember when I was a lot younger, we were doing cleaning of a post-abortion care, and there was a delay between the ketamine and the diazepam. Moses, I think you mix them together. Or do you give them separately? You give them separately, but I do not know how much time should be in between. But should you give a fairly high dose of ketamine and you delay to give the other one, then you might see a drama that can create situations of unpredictability. And if you are used to being predictable yourself, and you love being predictable, then you might curse the day Moses has given you that key to the use of ketamine. But that is not to say anything less than what Moses has said. I have simply said we have other options. When we seem to be failing on the conventional, we have other options that are not necessarily conventional. Ladies and gentlemen, thank you so much.